Right. Good afternoon, everyone, and thank you again for joining us, or good morning, depending on where you are calling in from today. My name is Catherine Freeland, and I'm the Associate Director of Public Health Research at the Hepatitis B Foundation. Again, I'd like to send a warm welcome to everyone joining us today, and thanks to those of you who have already introduced yourself in the chat. If you've not done so, please feel free to do that by putting in the chat box your name, your organization, and where you're calling in from. I'm very excited today because we have a really wonderful presentation in store for you about how we think about engaging and improving perinatal health outcomes through the lens of hepatitis B. And we're looking at Uganda specifically and how the community has led really wonderful efforts to do that on the ground. So we have two wonderful speakers, Arafat Bombale and Masika Fatina, both here to present their stories and work from Uganda. So we're happy for that and welcome them to today's session. Just a bit of housekeeping for you as well. This session is being recorded, so you will be able to view the content of today's webinar following the session on our YouTube page at the Hepatitis B Foundation, and all registrants will receive a copy of the webinar, and we'll be sure to share that with you. Unfortunately, we're sorry to not offer translation today, but you can use the chat features, and we can use translate if we need to, if you have specific questions. But everyone is in mute mode. Please use the chat feature or the question and answer feature if you do have questions. Before we jump into the content of today's webinar, we do want to share a little bit about the Hepatitis B Foundation and also go into some of the global updates and guidelines for perinatal prevention in the US. The Hepatitis B Foundation is a global nonprofit organization that's dedicated to finding a cure and improving quality of life for the focused research, promoting disease awareness, supporting vaccination and treatment initiatives, and serving as a primary source for accurate information around hepatitis B for both the public, the lived experience community, and those researchers and medical and scientific bodies. I want to also share with you, if you're not aware, we have a new coalition which was launched just this year, the African Hepatitis B Advocacy Coalition, which works to unite and build up African-focused organizations, particularly community-based organizations, in the fight against hepatitis B, really focusing on capacity building, empowerment, resource mobilization, data sharing, working really towards elimination goals and sharing best practices so we can work together collectively to improve the network and synergies around hepatitis B activities. So very briefly, just to set the scene for us today, why are we focused on perinatal prevention? Really, if you look at the Africa region, we have about 65 million individuals that are chronically infected with hepatitis B, according to the World Health Organization reports. This is a significant burden and the second highest burden by WHO region globally. So we have a lot of work to do to really work towards this prevention. Most people in this context also are not diagnosed or treated. So we have a lot of work to do to make sure people are getting tested and linked to treatment. And why are we talking about perinatal transmission? But if we look at it globally, perinatal transmission, and particularly within the African context, is the highest means of transmission of hepatitis B. And so we really want to work to prevent the cycle of infections and protect new generations from hepatitis B. In terms of how we prevent it, based on the new 2023-2024 WHO guidelines that were more recently released, it is recommended that all infants receive the hepatitis B birth dose as soon as possible after birth, within ideally the first 24 hours of life. And then the birth dose should be followed by at least 2 or 3 other doses of vaccination. In many contexts, this is the pentavalent vaccination series administered at 6, 10, and 14 weeks. The birth dose is really critical because it protects the infant in the most vulnerable time of their life, that first 6 weeks prior to receiving that other dose of the pentavalent vaccination. And infants who are exposed during this time also have the greatest risk of developing a lifelong chronic infection of hepatitis B. So they're the most vulnerable during this time, which is really why we're focusing on this effort. The WHO guidelines also focus on other means, so thinking about the mother during this time, including recommending testing for all pregnant women and adolescent girls for hepatitis B surface antigen, which is the marker of hepatitis B infection. Um, they should also be tested for HIV syphilis in addition to hepatitis B. Anyone positive and pregnant for hepatitis B should be assessed, if possible, for hepatitis B DNA viral load or e antigen, which is an indication of e antigen positivity, is an indication for high viral load. So, either of those options, if possible, and then linked to treatment if the woman is positive and e antigen positive with elevated hepatitis B DNA. If that additional testing is not recommended, the WHO does recommend initiating treatment. Why? And the treatment is tenofovir, TDF. Why are we recommending treatment? Really to reduce the viral load of the mother. It's been shown to be elevated during pregnancy. And so if we reduce the amount of the virus in the body, then we're reducing the risk of transmission. So with that, I hope that is a helpful summary of the strategies and public health approaches to hepatitis B perinatal prevention. Now I'd like to hand it over to our wonderful speakers today, who will be talking about strategies that they've used in Uganda to really think about implementing these approaches. I'd like to first welcome Arafat Bombale, who's the head of policy program officer at the Great Lakes Peace Center. And in 2021, he was a hepatitis elimination champion for his contributions to advancing hepatitis efforts. Arafat has really done an amazing job at really elevating those with lived experience and also the community to really lead implementation and global efforts towards elimination in Uganda. And so we're thrilled to have him share some of his lessons learned with us today. I'd also like to introduce Masika Fatina, who's the program manager at the Great Lakes Peace Center, and she's currently implementing the hepatitis B project in the Rwenzori region, and she brings over 7 years of experience in humanitarian programming and strategic partnerships. With that, I'd like to pass it over to my colleague and friend, Arafat, to present on unlocking hepatitis elimination in the African continent. So Arafat, over to you and welcome.
Yeah, thank you very much, Catherine. Thank you very much for the wonderful introduction. I'm always inspired by the words said by the former president of Tanzania that it can be done, play your part. So after we had graduated from university, we felt that it was very important for us to come up with our humble contribution to ensure that one of our colleagues is a person living viral hepatitis, and we were wondering what we can be able to contribute. And this is the birth on how we started on to put in place Great Lakes Peace Center. So next slide, please. Next slide, please. Yeah, so what is our vision and mission? We envision a society where young people, women and men, are civically empowered and productive for their healthier, a peaceful, violent-free society, having young people being involved. Like I told you, our Great Lakes Peace Center is a grassroots youth-led organization that we midwifed with my colleagues, and this was one of our vision, but also importantly, empowering, mentoring, and transforming the lives and community in the Great Lakes region to take full responsibility of their health, peace, and enact positive, lasting peace. Next slide, please. Yeah, so what have we been up to in terms of Great Lakes Peace Center? Like I already alluded to the fact that we are a grassroots, which started in 2015. We are located in Kasese, Uganda, but we have a team of volunteers, young ambassadors who help us to do some of these initiatives. And we have been able to reach out about 4,000 volunteers since the time we started this organization. Next slide, please. Yeah, so basically what we do at Great Lakes Peace Center, we have been able to support the works in areas of viral hepatitis in terms of elimination, but also importantly, HIV-affected and infected families, orphans and vulnerable children, in our place, especially Kasese, which has been having a lot of recycling of conflict, but also importantly, working along with the youth and communities to promote well-being and fighting gender-based violence in terms of offering social support. Like recently, we had a gender-based violence clinic to support the rural women in terms of bringing a game change in supporting gender-based violence, but also bringing in international understanding of peace building in our community. Next slide, please. But all this is done through collaboration. The other important thing at Great Lakes Peace Center, we've been at the heart of doing advocacy in terms of having quality responsive care, and also interacting with government to ensure that they allocate money to bring in a policy shift and introduction of the birth dose. Like we already alluded to the fact, like on 19th of December last year, we met Parliament to tell them that it's very important for us to have the birth dose. But also importantly, we have been trying to work with other civil societies in Uganda, where the government of Uganda was able to allocate about $1 million US to support the elimination of viral hepatitis, especially putting money on the adult vaccination. Next slide, please. Yeah, so we have been able to mobilize in terms of work and success. We have been able to mobilize over 300 young people across our continent, and Great Lakes, we are proud to associate with all our friends throughout the continent who are able to bring in the works of the young people, but also to spotlight issues that affect stigma, discrimination. And most of the young people have always told us when someone receives these results, being told that you are living, we have been diagnosed with viral hepatitis, there's always discrimination and stigma among them. But also importantly, at Great Lakes, the works we have been able to do, we have been able to do the No Help Mama campaign by encouraging the rural women where we work to ensure that they are able to come and attend antenatal care, but also to avoid the outside birth by the traditional birth attendants. It's very important for women to be able to come and give birth in the facilities. Next slide, please. Yeah, so we have been able to do one important thing in terms of raising awareness in the local language, especially our local language, Lukonzo, but also other languages, because I know for sure if you spoke with someone in a foreign language, you are talking to them through their heads, but if you spoke with them in their local language, you are speaking to their hearts. And we have been able to, to give a different to bring in a different perspective about the viral hepatitis. So, but also importantly, in terms of success, we have been able to introduce Uganda. We have been able to work with the other civil societies to introduce birth doors, especially Parliament brought Ministry of Health, was able to introduce birth doors. I'm happy to say that in every facility in Uganda, at least if a mother delivers from the facility, they are able to they're able to vaccinate a child. The only challenge that is still there is the uptake of the vaccine. Next slide, please. Through different works we have been doing, I'm happy to say that we were awarded the SDG Action Award in Bonn, that is 2018, after we had also talked about what we are doing within our places. But also, like Catherine said, in 2021, was personally given an award for being a world hepatitis elimination champion, as we try to make efforts to eliminate viral hepatitis. But also importantly, we are part of the working technical group with the Ministry of Health in Uganda. And this should be able to inspire other civil societies that when you do some good work, you're always brought in to work with the technical working groups. And I would encourage other civil societies also to be part and partial of these technical working groups, because it brings your visibility, it brings your work to be known to all the stakeholders. Next slide, please. Those are some of the pictures when we were being awarded for the SDG. Next slide, please. As our success. Then there we were doing the school health clinic where we talk about screening of STIs, but putting focus on HIV and hepatitis infection, viral hepatitis. So through raising awareness through the school health clinics, this is very important for us to be able to eliminate viral hepatitis. Next slide, please. Yeah, so I think to the best of my recollection, most of you remember that we are going through a difficult time during the COVID-19. Personally, and my other colleagues at Great Lakes Peace Center, we have a register of all the people who are living viral hepatitis at different profiled health facilities. And during that time, we had a lockdown and people would not be able to move. But we are lucky that government gave us an opportunity to deliver these medicines. If you look at on your left, that was myself delivering medicine to the profiled patients who were elderly, some were women who are not able to come to the clinics. Then I was with my colleague whom we worked with him during the COVID-19. Next slide, please. Yeah, so I'm happy to say that we, under the Peace Initiative, we work with the Rotary Peace Center of Makerere. That is a fellow who had come in, but joined our work at Bwera General Hospital as we are trying to introduce the campaign for pregnant mothers and also hepatitis B, hepatitis B birth dose introduction. And I'm hugely indebted to my colleague who came all the way from Botswana to come and concretize our efforts in the rural villages as we interacted with the pregnant mothers at Bwera General Hospital. Next slide, please. So these are some of other campaigns we have been involved in terms of community testing, vaccination, and also going to the sites. I think if you looked in the photo, you can see we are screening, but also importantly, we are able to go to the targeted population, like the people who work at sites, construction sites, to ensure that they're able to test, they're able to be vaccinated, and then linked to care. And once that is done, you are able to you are able to eliminate viral hepatitis. Next slide, please. Yeah, so in terms of localization, those are some of the campaigns when we were meeting the village health teams, or there would be the community health extension workers, to tell them that it's very important to share with the local materials in terms of IEC materials, information, education, and communication materials in the local dialects. And that was our outreach in one of the clinics that we always conduct back here at Great Lakes Peace Center, with also, of course, profiled health facilities that we work with. Next slide, please. Yeah, so I think Mwasinja, but in summary, if we are to get to the viral hepatitis elimination, we must ensure that all people know their status by testing. We must encourage vaccination, but also we need to link these patients who have been diagnosed with viral hepatitis. I want to thank you very much for listening in. Without much ado, I think at this juncture, I'll be able to bring in my colleague, Fatna, who is now going to walk us through specifically our campaign, the No Hep Mama, which we are doing to address perinatal hepatitis B in Uganda, particularly in Rwenzori. I think let me allow her to make her presentation. I thank you.
Thank you, Arafat. Thank you for the good remarks, background of the organization. I hope I'm loud enough. Hello, Catherine.
Yes,
We can hear you.
Yes, we can hear you.
Okay. Thank you. Thank you for the opportunity. This juncture, I want to, of course, dive into addressing perinatal hepatitis B in Uganda. What we would, us as Great Lakes Peace Center, we usually say it is No Hep Mama. It is a project we've worked on before, just like Arafat has mentioned in his slides, that we engaged mothers in different facilities and village healthy teams on the campaigns of No Hep Mama. Next slide, please. Yes, the background on how we came up with the project. Globally, we know that it is 254 million people that are living with hepatitis B. Africa accounts for 63% of all new infections, according to World Health Organization. Hepatitis B is prevalent in Uganda at 4.3% among adults. And although the interventions for prevention and treatment of hepatitis B are still, the virus still exists, and hepatitis B virus at birth dose, routine immunization, adult vaccinations, policies and guidelines, triple elimination strategy, what we are working on now. And of course, we know that we have challenges still existing, including late identification, low leakage to care and low retention in care, high service and the cost of the RDT in Uganda estimated at $0.9. These are the biggest challenges and that keep hepatitis B moving in our communities. Next slide, Catherine. Okay. As Great Lakes Peace Center, together with our partner, Alliance for Children and Youth, were funded by Gilead, a pharmaceutical company in the United States of America, to implement a project accelerating hepatitis B epidemic control in Kasese and Toroko districts of Rwenzori region in Uganda. The project selected or identified healthy facilities in both Kasese and Toroko districts. The healthy facilities in Kasese are Bwera Hospital, Kataduba Healthy Center 3, Rukoki Healthy Center 4, but also to mention on the same point of Rukoki, I would like to say that it is now a general hospital, and then Karambi Healthy Center 4. In Toroko district, we are in Rebsengo Healthy Center 4, and Karukutu Healthy Center 4. Just like I've mentioned, where are we? We are in 6 facilities that we identified. When did we start? We started in June 2024 till now. And who is our funder? That is Gilead, a pharmaceutical company, which is helped us, which is funding us as GLPC and Alliance for Children and Youth Uganda. Then what is the project? As I had mentioned, we are accelerating hepatitis B epidemic control in Kasese and Itoroko district. Next slide, Catherine. According to the project, the overview is to increase the proportion of pregnant mothers who know their hepatitis B status from 43 and 42 in Kasese and Toroko district, respectively, to at least 50% by June 2025. I would like to mention on this that as we are still implementing, we are basically working on the statistics to see and compare the percentages where we are now. Yeah, the slides or the presentations I'm having now may not show the exact number of people where we are or the percentages, but we are still in the field and we hope to communicate next numbers or the real numbers in the 2 months to come. And the second is to increase the proportion of hepatitis B newly diagnosed pregnant mothers enrolled in care and treatment from 23% and 10% in Kasese and Itoroko districts by 10% respectively in June 2025. And also the third is to strengthen community governance and civil society involvement in viral hepatitis service delivery in Kasese and in Toroko by June 2025. On this part, we've really tried doing the awareness and sensitizing the communities, as we shall see in the next slides. The main goal of the project is to prevent new hepatitis B virus infections and that persons who are already infected are tested, informed about the infection, and provided with high-quality counseling, care, and treatment. We've done some follow-ups, and we've managed to work with expert clients in the identified facilities. The expert clients who have been oriented, brought back on board, and those who have been lost out of the collecting the drugs and then the care from the facilities. After the orientation, they've managed to reach the communities and identify people or encourage people to have their screening and then counseling in the facilities, and also if found positive to be on treatment and care. Next slide, please. Okay, the project strategy. is single triple elimination. What I forgot to mention earlier is that the project is leveraging on government facilities and government resources. So that is where we are working with our local facilities, healthy facilities, the hospitals, because they are government, and we believe that most people in the communities have their services, medical services, in the government facilities. So we would not go private, and also because we needed the items or the vaccines and the test kits that are provided by government, since CSOs would not purchase or to buy and provide for everyone in the communities. So as we increase identification of newly infected mothers, this is quarterly in outreaches. We train VHTs to enable referral pregnant mothers. We actually oriented VHTs in the 6 communities who are linked to the 6 facilities, healthy facilities, to make sure that they get to understand what is hepatitis B, how can it be prevented, and how can someone catch hepatitis B? So all these were things that were trained and oriented to the VHTs so that they would support the pregnant mothers in their communities, but also to let them understand that this is a virus that can be caught by someone, just like HIV is. Unlike the past years where people would say that people are bewitched, this person has been bewitched, it's African chemistry. So we have managed to work in the communities to let people know that this is natural and this is a real virus that can affect communities in so many ways. And also by holding hepatitis B healthy camps. Of course, here we had pregnant mothers on board, very well mobilized in different communities to make sure they come and join the campaigns of hepatitis B to screen, vaccinate, and also be led to care if positive. And in the part of increase in enrollment of hepatitis B positive in care, here we orient, there was a variation of health workers on new hepatitis B guidelines. Of course, we hired consultants on this particular part for the health workers in different facilities who were trained on new guidelines according to the local government or to the government. So this made them understand and also increased their confidence on hepatitis B issues, because they're also humans. They would also believe what the parents say, that it is a witch, it is not natural. But of course, out of the testings and understanding what it is, so it made it easier, and people are now on board. We also identify and follow up clients who have missed referrals or their pills. We also reallocate hepatitis B supplies from overstocked facilities. Here we use the hub riders to survey and find out which facilities have more. The test kits are there, people not screening, the vaccines, and people are not vaccinating, especially pregnant mothers. So where that is, we make sure we find some stock or at least part of the stock to refer to another facility. Then subtext clients, this is what I mentioned, that was peer-to-peer learning.
Hi, Arafat. It looks like Fatina may have dropped off her connection. Oh, she's back. Fatina, are you there?
Yes, network.
Yeah, it's okay, no problem. Let's see if we can fix it. Let's see if we can hear you now. Go ahead.
You can put the screen. The
Yeah, the
slide
screen.
screen.
Yeah, go ahead. Fatima?
Yes, it hasn't yet displayed.
Oh, okay, this one?
Fatima, are you able to see that?
No. I'm not seeing the screen. I don't know why. The slide is not on my screen. I don't
Okay,
know why.
can I support you on that?
So my sharing request request.
Maybe, can you see it now or no?
Not yet, not yet.
Okay, maybe you can log back in again, and then Arafat, maybe you can take over until she's able to log in and see the screen. Is that okay?
Okay. Okay, that's perfect. Thank you very much. I've been personally also part of this initiative. I think I can be able to walk you through. So, in terms of the results of the project or what we have been doing, is that 63 out of 16,000, 1,619 were tested positive at antenatal care, and literally 3%, four of the one from Toroko, and then trained the VHTs, the community health extension workers, 36, and then we were able to have referred pregnant mothers 1,232. And then also the sensitization of mothers. When the mothers come for the antenatal, definitely our team would be able to go in and then walk through the mothers on why they should be able to test. And Catherine, can you imagine 9 out of 10 pregnant mothers did not know their hepatitis B status?
Wow.
And literally those who would attend the antenatal care. So it's very prudent that they are taken through health education, but also reinforcing the importance of testing and knowing their status, and they, where we need be, they can be vaccinated. And then those who are positive are linked to care in terms of prevention of mother to child transmission. Next slide, please. Yeah, so pretty much that is still what we have been able to do. We're able to sensitize 1,541 mothers, those who would come for antenatal and postnatal care. And then we were able to hold the camps where we would be able to test mothers. If you can see in that right side of the picture, where the mothers had come and were in sessions of telling them why it is important to test, but also importantly, they were being vaccinated during that time when they had the camps, the hepatitis B camps. Next slide, please. Yeah, so in terms of linkage and retention, like we had already, my colleague had already alluded to the fact that those who test positive would be able to take them, link them to care, but also make sure that they are on to their care to ensure that they suppress, they are able to suppress. And these are some of the these are some of the pictures we took when we were in the field. If you look at on the right side, but however, some of these had challenges in terms of orientation, in terms of mobility. Some of the areas we work in, Mount Rwenzori is very rugged and would get difficult in moving out. But also importantly, the stock out of hepatitis B drugs, especially tenofovir for monotherapy. But also, like we say, you always hear on the news that we always have floods cutting us means of transport. It's not motorable, it's not easy to access. That's why you see us sometimes use motorbikes, if you looked at my first presentation. But also importantly, we trained 36 expert clients, those who are persons living with viral hepatitis, but they would importantly tell the mothers how it is important for them to be vaccinated or to have the drugs, take them on time. But also we oriented 18 health workers on the revised guidelines, which are in for Uganda, and they also were able to follow up 46 clients who had missed their appointment. Next slide, please. Yeah, so in terms of yields, if you looked at vaccination throughout the district, we were able to improve, though the coverage was not all right. We did very well at the Katadoba, Rukoki, now General Hospital now, like my colleague had said. but also we are grappling with a few challenges in terms of these other health facilities. We had only two facilities which had the 50% coverage, but one of the most important challenge was that the vaccines were not available; they were out of stock, and certainly that affected our vaccination coverage. Next slide, please. Next slide, please. Yes, so throughout the, like I'd said, we at Great Lakes Peace Center, our aim is always to make sure that we make our humble contribution in terms of coming up with the innovations, new ideas on basically what can be able to do. Like I'd already told you that we have challenge with means of transport. Some women were being referred. So Great Lakes Peace Center, through our partners, were able to bring a mobile ambulance, which would carry pregnant mothers living viral hepatitis, pick them from their areas and bring them to the general hospital. And I think you can see just right in the corner there, there's a photo of our ambulance, which we have been using to get pregnant mothers being referred very fast to the profiled health facilities. We have been able to have a radio talk show, acquired distribution materials, and then also supporting the supervision of the district health teams to conduct the supervision in terms of are we achieving in terms of monitoring and evaluation. Next slide, please. So yes, I mean, we have been trying to do this campaign or project or ideas on how we can be able to concretize and enhance efforts in terms of prevention of mother to child. These are some of unmet needs in terms of implementing the project. A stock out, which I had already alluded to the fact that we run out of testing kits and also drugs, but also expensive testing among persons living with viral hepatitis, like liver function test, fibroscan, complete blood count, etc., etc. And then also hepatitis management at the low levels, health center threes. We have very many health center threes, but we have very few hospitals. I'm happy in this financial year, Rukoke has been made a general hospital. What now is needed is to enhance the capacity of those health workers who are working there. The other important thing is that the inadequate domestic funding, that goes towards the civil societies. We don't have our resource envelope is very limited, but also we have stigma and discrimination among people living viral hepatitis. Some people still think that viral hepatitis B can be transmitted through handshake, a hug, and something like that, and maybe a wizard moving on your body. And all these are myths. It's not correct that people can be discriminated or stigmatized because they're living viral hepatitis. Then the other thing is the knowledge, attitude, and practices among the health workers. The health workers tend not to also pay attention to the people living viral hepatitis. Then also issues to do with supply chain and infrastructure, keeping the cold chain. I mean, the hepatitis birth dose, how many fridges do we have at health facilities, health center 1, health center 2, health center 3? Next slide, please. Yeah, to wrap it up, we came up with the recommendations, and I hope that we have been able to share with the local administration, but also at the national level. Like I told you that we were able to meet the parliament last year on 19th of December, and these are some of the recommendations which we think can bring in the new energies to really concretize the efforts in terms of prevention of mother to child. We advocate for hepatitis B management at health center 3s across board. There's a need to mainstream hepatitis intervention against the ministries and development agencies. We need to reinforce the capacity of health workers in terms of the guidelines. All the health workers must be having the guidelines through training them in terms of capacity building, empower patients and communities to take charge of their health. I think all the programming of viral hepatitis should be patient-centered. I mean, we can't have solutions without the patients, and the patients must be at the heart of prescribing solutions in terms of eliminating viral hepatitis. Next slide, please. So overall, this has been done with support from Gilead and also Great Lakes Peace Center working with the local district, Kasese District Local Government, Ntoroko District Local Government, and then Alliance for Children and Youth in Uganda. Next slide, please. We wish to thank you very much indeed for getting in, but these are some of the additional photos coming in terms of what we of course, we came across lessons learned. Community engagement is very critical in terms of the patients themselves, but also the civil societies are very, very important. In terms of capacity building, the health workers need to be built, but also the civil societies have their skills must be built to enhance the service delivery. But also importantly, in a resource limited setup, we need integration with existing health systems in place. And then in terms of sustainability, the local governments must be able to own this. Then also youth institution university programs need to be targeted moving forward because they are the bedrock of health. And we are sure that if women and the youth are brought into the fold in terms of fighting viral hepatitis elimination, then we are really good to go. Next slide, please. Yeah, so just to wrap it up, what is important in terms of prevention of mother-to-child transmission is to ensure that there's testing, the pregnant mothers to know their status. Like I've told you in Uganda, most of the ANC mothers, pregnant mothers attending antenatal care, 9 out of 10 know their status. It's important they know their status. They need to be vaccinated, but also linkage to care. I thank you, and thank you for listening in.
Thank you. And Fatima, apologies for the challenges with the technical difficulties, but I wanted to give you an opportunity to add anything to what Arafat had said during the webinar, during the last bit of the slides.
Oh, thank you, Catherine. We need to build capacity. We need to make sure that our healthy facilities and health workers are really on board as far as hepatitis B is concerned. Because I encountered a situation where at the time of implementation, we brought health workers on board, we trained them through the consultants we hired. And after the trainings and other orientations, we thought that when they go back to the facility, they will do exactly what they were told. But to my surprise, going back monitoring, then also engaging them for
Fatina, are you still there? I think
She
network challenges there.
She seems to be in technical hiccups.
Yeah.
Yeah.
So what I wanted to talk about is ensuring that our health workers are really trained and emphasizing that every pregnant mother who goes for antenatal should be tested hepatitis B because they test especially syphilis and HIV/AIDS, and then forget the hepatitis B, even after they were trained, even after they were oriented about the virus. But in this time, this is to emphasize on that.
Thank you. It looks like Arafat, Fatina may have dropped off again. Sorry, everyone, for the technical challenges. We can't necessarily predict networks and all of that. So apologies for that. I think I do want to get to some questions. I think Fatina was just highlighting the importance of testing all pregnant women for hepatitis B. I agree. I think this is really critical. So we can figure out how we can implement this during antenatal care. And it sounds like the strategies that you all were using on the ground was really impactful. So thank you for sharing those. I wonder if we can jump into some questions for each of you because we do have a few in the chat. One of the questions, and maybe Fatina, hopefully your network is back, you might be able to answer this question, but how can you motivate pregnant women to attend the hepatitis camps? And can you share a bit more about the logistics of the camps and how long they last and what they were like and what information was covered? Over to you, Fatina. Hopefully your network is okay.
Oh, Catherine, I didn't get it well, please.
No problem. The question was, can you share a bit more about the hepatitis camps that were being conducted, who attended, how they were motivated to be attending those sessions, and then what information was covered during the camps?
About the healthy camps,
Yes.
And of course, the outreaches. We had to reach the facilities. We engaged village health teams, those are VHTs. Engaging VHTs helped us to reach the communities and the people in the local setting. So the VHTs took the message to the mothers, especially, or to the pregnant mothers, come for the screening and vaccination. So this helped us so much, but also through mobilizing, we used different modes of mobilizing. We used megaphones to move around the communities, which was successful, as we did this for 3 to 4 days, moving around the communities because they are hard to reach areas that need more moving or more mobilization in different areas, but also to make sure that at least where we've reached, everyone would come and reach the health camp and also of course, this was supported by the facilities that we also allocated to also working with when we had nurses, counselors come on board, and the facility in charges to support on health talks at the time of the campaigns or the health camps. So this was really
Thank you. Yeah, that's very helpful. So it sounds like using health talks for healthcare workers, and then also thinking about direct outreaches to the community through mass education and megaphones was a way to really spread awareness as well, which is really great.
Yes,
RF,
maybe if I'm to add on,
yeah, please.
the other important message which was coming out very clearly is that whoever would come for antenatal care when they're a couple, husband and wife, to come and attend antenatal care, they would be given the first priority to be tested for their hepatitis B, status, but also given priority to be the first one to be vaccinated, and then also, giving them a mosquito net. And like my colleague had said, we are leveraging on the existing structures of government. And I think that was a big deal. Thank you.
Thank you so much. And in terms of the trainings for the healthcare workers, can you talk about the acceptability of the hepatitis information and education they were receiving and the acceptability to implement that? Maybe Arafat, if you could start, and then we can go to Fatina for additional comments after you respond.
Thank you. In terms of acceptability, is that, like my colleague Fatna had alluded to the fact that we are using the existing structure of government. For example, when we went to the Health Center 3 and Health Center 4 and the General Hospital, would use the medical superintendents, the healthy in charge, to communicate that we shall be implementing a project together with them. So they had to ride the horse by its horns. They are the ones doing the work. Fatna, myself, would just go there and be each other's keeper. We would just see them do the work themselves. So I think that also brought them on board. But also importantly, in terms of the village health teams, who are using the local dialects in terms of using Lukonzo, so that they really understand, would talk to their hearts rather than their heads. And I think that was also another important thing that made our campaign a little bit easier than we had thought. Thank you.
Thank you. Fatina, anything to add to that?
Oh, yes, Catherine. It is just well mentioned, only that I was checking questions here in the chat. Someone asked, what do we do for the babies born with HBV? I think Arafat would be in position to answer that. I wanted to talk about the adult vaccination. Was it free? Yes, the adult vaccination was very free. And even up to now, it is what we are campaigning, because we need to make our communities free from HBV. Thank you.
Yes, in terms of the children born with the hepatitis B, would refer them to the pediatrician who works at Bwera General Hospital, but also they will be reviewed by the doctors at Rukoki General Hospital. But also FATNA, like you remember very well, is that would always have challenges of stockouts, vaccines, and issues to do with the drugs, tenofovir, and also logistics and supplies. In those situations or scenarios, certainly we would always procure or buy and make sure that we really complement. But we are very delighted to the efforts of government, and I'm sure the meeting which we had on 19th of December last year with the parliamentary health group on infectious diseases, notably hepatitis, would be able to, allot more money in terms of sustainability. Because if the local domestic funding is available, then we can move miles in terms of prevention of mother-to-child transmission. I thank you.
Thank you. Another question that came in, any thoughts on how Uganda can expand access to hepatitis B treatment among pregnant women? And also with this viral load testing as a follow-up for positive pregnant women?
Okay, thank you very much. In terms of expanded program for immunization, Uganda has concrete expanded program for immunization. What now is needed is the government commitment to add more money to ensure that the donors and other people pull money. Like, for example, I saw something to do with Gavi. If our government has already applied to get money in terms, and they include the hepatitis birth dose, that would be a magic. It would be a magic thing, because then the structures are there. The structures are there to ensure that the vaccines go all the way to reach down. I'm keeping my fingers crossed that the resource envelope that goes to the expanded program for immunization in terms of the division of vaccination in Uganda, there must be money that is put there. And once the money is there through our advocacy, then we shall move miles. So the good thing is that in Uganda, the Minister of Health, the president or the chief executive officer of this country, our permanent secretary, are very much committed in terms of the viral hepatitis immunization. And no wonder in 2019, we had the African Hepatitis Summit in our country, Uganda. And then also the coming week, we shall be having the conference on triple elimination of viral hepatitis, PMTCT, in terms of HIV, syphilis, and hepatitis notably. So I'm sure the political commitment is there. As advocates or patient advocates, we need to interest our governments into such areas of viral hepatitis, and really we shall be able to move, or we shall be able to dig bigger ground than we are doing. I thank you.
Thank you, Arfat. Just a follow-up to that question. I think many individuals are wondering maybe how you were able to get the buy-in of those high-level officials at the Ministry of Health in Uganda. Do you have any thoughts on how that came about?
Yeah, thank you very much. Just maybe if I'm to walk you through the memory lane, is that we have very many distinguished advocates in Uganda, and under the Ministry of Health, we have what we call the Technical Working Group, where we belong, the Great Lakes Peace Center, the Organization of People Living with the Hepatitis in Uganda, and other civil societies. So we work very closely with the Ministry of Health. Number one, the approach of patient-centered approach to ensure that the people living viral hepatitis were the ones to be able to talk about themselves and say, please, we don't have viral load, screening. We don't have test kits. When we go to the facilities, the services are not there. And together, we're able to be part of the technical working group. So some of the advocates in other countries, especially in the mother continent, they need to find a way on how to work within the Ministry of Health and create social capital there, because they need to work with social capital. They need to work with the members of parliament. For example, my member of parliament is a good friend of mine. He knows me as a patient advocate. So they'll need to walk out of their comfort zone to ensure that also they befriend people who matter in their country. And the people who matter in the country are legislature. Because when we talked about that, the money was allocated, and they're the ones who allocate resources. So to face it frankly, my colleagues who are working in different countries must be able to befriend the powers be. And the goodwill, of course, of government, the permanent secretary knew the burden like you can imagine, Catherine, in Uganda, 80% of people who are at the Cancer Institute are patients of liver disease. So that's a big, a big advocacy message you can share. And, can you imagine 9 out of 10 women who attend antenatal care do not know their status. So these are some of the statements which we are making. And we are telling them that, that viral hepatitis birth dose is a magic. It can change everything. It can prevent the mother to child transmission. And I think these are some of the key messages which we are doing. And then we ended up getting it to the Ministry of Health, but also learning from others. We are learning from senior advocates, the likes of Kenneth Kabagambe, and to mention but a few. How do they do them? So we shall need all of us to do sort of advocacy capacity building. When do you say what? When you meet the powers to be. I thank you.
Thank you so much. So it sounds like being part of a long history of strong advocates is a huge benefit. I think many countries are just starting, to figure all of this out. Any insight into getting engaged with this technical working group and how one might be able to go about doing that? I think many countries also may not have these technical working groups as well. So is that something that the government formed out of request from the community? Or was that?
Yes. When we realized that there was a HIV technical working group, malaria technical working group, new infection, asphyxia, there were sort of ad hoc committees already existing. So what I would advise my fellow advocates is to identify one of the technical working groups already in the parliament, already in the Ministry of Health, and then you write a formal letter either to the permanent secretary or to the head of that section or commissioner or the head of department to ensure to request and say, can we be part of your conversation? And then reaching out to the to the implementing partners within the Ministry of Health. That greatly influenced the formation of the technical working groups. Thank you.
Thank you so much. That's very helpful and hopefully inspiring for others to learn from as well. Another question that we received is thinking about sustainability of this program beyond the funding that was received. Can you speak to that? Maybe Fatina, we can go to you first.
Thank you, Catherine. The sustainability of the project, of course, will depend on what kind of people we have that we are meeting. I would like to say that here, people to project move in because people are already giving positively with and also encouraging the newly the new people that they should be positive. So I think that the hepatitis, also sensation and awareness in the communities would really keep the stability of the project, but also in the antenatal section, keeping the pregnant mothers in the know that
Arafat, anything to add? I think Fatina hopped out and I think her audio is a bit difficult to hear.
Yeah, he continues to experience technical hiccups. But what is critical is that if you looked at the design of the project, is that we are leveraging on the existing structure of government. And I think my fellow advocates, if they want to also succeed in terms of implementing some of these projects, is that by and large, we must work with government, with existing structures. Once that is done, then we are just good to go. Then the other thing is that I thought Fatina would speak to this, but let me just say that some of the women who are living with viral hepatitis B, specifically those who were identified, is that we are trying to get them into the formation of saving and credit groups so that their peers, they tell their stories, they are into handcraft, and we have also come up with an initiative of making coffee at Great Lakes Peace Center. So these rural women or the young people, the volunteers, are put into the coffee process, the value chain. They are able to pick the coffee berries, dry them, and when they bring them to Great Lakes Peace Center, we buy the coffee, and then so we just do value addition and we sell. And most of the people have met me in different conferences. You see me with coffee, I keep selling coffee, and all these proceeds go back to those women group which are doing saving and credit. And I think that's a more sustainable way how we can also support this. The other thing we have done is that through FATNA, she has been implementing what we call the nutritional master plan with people living viral hepatitis, to be able to tell them about how can they be able to generate the kitchen gardens to make sure that they enrich their diet. So those are small things we do in a great way. I thank you.
Thank you. That's a great answer. And I think thinking about creative means for funding for viral hepatitis activities and also just holistic health, I think is really important. And I appreciate the creativity for those strategies and efforts. One last question before we close the webinar today. Do you envision the strategies that you've learned from and implemented being rolled into other areas beyond Kasese? And do you envision other challenges for implementing this in other areas as well?
Yeah, thank you for the good question. Really, when we were drafting this project, or when we were drafting the project, was to really accelerate the efforts to eliminate viral hepatitis. We wanted to start with about a region, but our region here in Kasese, the Rwenzori region, we're about the 11 districts, which are very many. We started with 2, but looking forward, we can always share or find a way how we can be able to implement, this project in other areas. One of the tangible thing we shall be able to do is the work plan. At the end of the, we are already having work plan. We can expand them, but also to develop the local government strategic plans. What is their question? What is the hepatitis question in terms of what can they be able to do in terms of the law, in terms of policy, to answer this bigger question? Because the burden of viral hepatitis, it comes with liver cancer, it comes with other infections. So what do we do? So we shall be able to come, we get other people on board. The other more way we want to do it is that we are already working at the Ministry of Health with as technical working groups. We shall be able to again revisit the members of parliament and tell them they need to do the domestic funding to ensure that we expand our works. And I'm sure once that is done, we shall be able to have a lot of resources. Now, the challenges that come with such projects certainly is the small resource envelope. That is one of the biggest things. But we look very much forward as Great Lakes Peace Center to continue sharing our successful stories, our challenges, so that together we can prescribe solutions to the prevention of mother-to-child transmission on mother continent, but also globally. And we're always very much available to share or to cross-fertilize our ideas with all other stakeholders, especially on the mother continent. And we teach them or we share with our experiences so that they can have lessons 1 or 2 to be able to implement in their areas. Thank you.
Thank you so much. Fatina, any last comments from you or additions to that previous question? Hopefully your network is okay. It's not working. Oh, we can't hear you. Sorry, Fatina, and sorry everyone for the technical challenges, though. We know that it can be difficult to have strong networks in different areas, so we just want to apologize for that. But I think we've learned a lot from this conversation. I think we could continue to have this conversation, but want to make sure we're respecting everyone's time. We will be following up after this webinar with the recording of the session. If you do have any additional questions, you can always reach out to the email that was sent to you by Zoom, and we're happy to respond to those questions that you may have. I think there's so many different topics that we learned from today, from advocacy and strong community-based partnerships and implementation, and strategies for addressing some of the challenges that we experience on the ground. I want to take a moment to appreciate our 2 speakers, Arafat and Fatina, for spending their time with us this morning. I hope that you have both seen in the chat the warm appreciation from the attendees from the session today. It's been very insightful, and really appreciate the great work that you're doing in Uganda, and look forward to thinking about how these strategies can be implemented in other parts of the continent. So again, thank you both so much. And thanks all of you for attending the session with us today and spending your time with us. We look forward to seeing you on our next webinar. And I hope that you all have a productive World Hepatitis Day, which is July 28th. Thank you all so much for your time, and we'll see you next time. Thank you. Thank you so much.
Thank you very much, Catherine. Thank you, everyone who came in to listen in. Bye.
Bye, everyone.
Bye.
Thank you.